Okay.
Tommaso. We'll move on to the next speaker, who's Professor Dirk-André Clevert from the University of Munich in Germany, who's the professor in the ultrasound section chief and professor in the ultrasound section. And of course, he's been well known for many years in Germany as the forefront of contrast enhanced ultrasound. And of course on a worldwide basis as well. He's going to talk to us this afternoon of the advantages of using contrast enhanced ultrasound in liver diagnostics. Dirk, go ahead.
All the other colleagues from the world, so should I say good morning, good afternoon, or good evening. Today I would like to speak about the advantage of contrast ultrasound in the liver diagnostics. So liver lesions have got a prevalence of around about 5% in the whole liver in the population. But unfortunately, patients with hepatic metastasis have got in 20 to 50% of the cases at the time of diagnosis already liver mets. Therefore, it's very essential to make reliable diagnosis in order to offer the best treatment for the patient. So is there really a need for using this technique? So I share with you 4 different lesions. And if you take your time and look carefully at the screen, you will see that these 4 lesions look very similar. Unfortunately, there is only one liver mets. So the key question is, where is the liver mets in order to offer the patient the best treatment? How does ultrasound works? So you see the diameter of the ultrasound. The first generation was filled with air. Nowadays it's filled with gas. All bubbles has got a shell, either it's a palmitin shell or a lipid shell. And the most difference between ultrasound and other contrast agent is that we are speaking about a pure blood-pool contrast agent. So they will stay in the vessel. They will never leave a vessel except you have got an active bleeding. How it's working, you see the sound wave from the probe compressed and decompressed the bubble. You see the oscillation of the bubble, and when you have got software on your system, you see the oscillation of a single bubble. If you try the same without contrast software, you will burst this bubble immediately. It's important to have got an informed consent from your patient. These contrast agents have no influence on renal or thyroid function, and the amount of contrast depends a little bit on the probe you're using. So it's around about between 1.2 to 2.4 cc of contrast, followed by 10 cc of saline. In the liver diagnosis, it's very essential to look at these 3 phases. One is called the arterial phase. It's between 10 to 15 seconds, following by the portal venous phase, 30 seconds to 2 minutes. And after 2 minutes, we speak about the late phase, up to 5 and even sometimes even to 6 minutes. In this talk, I will cover most of the benign lesions like hemangioma, FNH, adenoma, liver cyst, or focal fatty sparing. On the other side, I will also speak about malignant liver lesions like liver mets, HCC, and CCC. Starting with the benign liver lesion. So remember, we have got the 3 phases. A hemangioma have got a perinodular enhancement in the arterial phase. Over time, this nodule will be growing, and with no thrombotic changes inside, the hemangioma should have a complete filled with contrast. So if you look at the animation, you inject contrast, you see the perinodular enhancement, you see these nodules. Over time, you will see an increasement of these nodules, and at the end, the nodules are completely filled, the hemangioma, no washout. So we see this bright lesion here in the liver. This lesion doesn't show major vascularization by using the color Doppler option. In the next step, we inject contrast, and don't forget to push the timer. you see pretty good this perinodular enhancement over time. You see these nodules are growing and growing. Then we will switch to the portovenous phase. You see this lesion is nearly completely filled in the portovenous phase. This is around about 1 minute after injection. And if we go to the late phase, it's completely filled, so classical hemangioma. Sometimes we find very, very strange lesions like these huge lesions. No major vessel in the color Doppler. This is also a hemangioma, so we have to prove if we inject contrast. You see a very similar enhancement. You see this nodule here over time. You see these nodules are growing. This hemangioma has got a diameter more than 10 centimeters. We have also a pretty good penetration up to 20 centimeters in this direction. If we go in the later phase, you see these nodules are growing. And if we switch to the late phase after 2.5 minutes, you see this is a giant hemangioma with thrombotic changes in the center, but this is not a mass, it's just a giant hemangioma with some thrombotic change. There is no need to biopsy proof of this lesion. Another lesion is the FNA. How does an FNA behave? So in the arterial phase, we have got a very, very strong uptake from the center to the peripheral. In the portovenous phase, it's iso or hypergenic, the same as in the late phase. Keep in mind that only 60% of the FNH have got a central scar. So if we inject contrast, there's the FNH, sometimes difficult to see in the grayscale. A strong uptake from the center to the peripheral in this direction. Very fast. It's like a flashlight. You push a button and you see immediately the strong uptake. There's central scar. And now you see also at the end the complete filling of the liver, no washout in the late phase. So we see there's a lesion. Is this typical for an FNH? By looking at the color or power Doppler information, we see a couple of very strong vessels inside of this lesion. Also here in the middle, there are some vessels. Then we inject contrast. You see there is a lesion from the center to the peripheral. Very, very strong uptake. There's another one here. So we wait a little bit. Now we switch to the portovenous phase. Even a very strong uptake. Also, we see the sign of central scar there. Then we switch to the portovenous phase and late phase, still hyper-enhancing of this lesion with a central scar. So typical behavior for an FNH. Also here, don't forget to look at the late phase. Still, after 2.5 minutes, no washout, so FNH. Adenoma are a little bit tricky. So they have got a hyper-enhancing from the peripheral to the center. There should be have got an iso enhancing in the portovenous phase and iso or slight less enhancement in the late phase. So if we see the adenoma, we see a strong enhancement in the peripheral, a fitting from the peripheral to the center, and in the late phase, sometimes you see a slight washout. It means a little bit darker, not a complete washout, a little bit darker in comparison. Often we also have got this rim in the peripheral. So we see there's a lesion. Close to the capsula is another lesion. This lesion has also some feeding vessel here in this area. In the next shift, we use contrast. So we inject contrast. Also here you see the enhancement, a little bit different in comparison to the enhancement from the FNH. You see these hyper-enhancing take a little bit longer. Now it's hyper-enhancing. Also we have got this rim in the peripheral. And if we now switch to the portovenous phase, still hyper-enhancing, late phase hyper-enhancing, so typical pattern for adenoma. What about focal fatty infiltration or focal fatty sparing? Very easy. It's liver with less fat or with more fat. So the main tissue is liver. This means this lesion has got iso enhancing in the arterial phase, same in the portovenous phase, same in the late phase. So we see a focal fatty sparing here. If we inject contrast, we see this lesion have got the same contrast behavior like the surrounding tissue, no washout in the late phase. Often we find these focal fatty sparing close to the gallbladder. You see in color Doppler there is no major vessels inside. If we inject contrast, you see in the split mode, there's a lesion in the contrast. Same contrast uptake like a surrounding tissue. If we wait a little bit longer, you see also here, in the portovenous phase, same enhancement, no washout. Late phase after 2 minutes, no washout. So just a focal fatty sparing, very quick, easy diagnosis. Liver cysts are also very easy because normally a liver cyst, if there is no active bleeding in the cyst, there should no enhancement. So if we inject contrast, you will see there is a complete dark area in the liver without any contrast uptake in all 3 phases. Often we also see this kind of posterior enhancement in the back. There was a tiny lesion seen there. There's a lesion close to the capsula. Here's a lesion. The question is it really a cyst or a liver, maybe a liver mets? By injecting contrast, you see there's a lesion in the grayscale. There's a lesion in contrast. You see an enhancement in the peripheral, but the lesion is completely filled. There's no bubbles inside, so completely dark. And even if we go to later portovenous phase, it's dark. Late phase is dark. So it's just a normal liver cyst. Even here, no need for treatment. On the other side, we also have to cover malignant liver lesion. Like how does liver mets behave? Depending on the primary tumor, they have got hypo or hyper enhancement in the arterial phase. In the portovenous phase, often they have already washed out, the same as in the late phase. So there's a lesion. You inject contrast, you see the strong enhancement, but also a very fast washout, much faster in comparison to HCC. So we see there's a lesion, hypergenic lesion with a diameter around about 3 centimeters. So we proved the vascularization in the color Doppler and in the power Doppler. So it seems to be no major vessels inside. The next step, we inject contrast. There's a lesion. So this lesion shows an hyperenhancement in this area. So we wait a little bit, and you already see in the portovenous phase that this lesion starts to wash out very soon. Once this wash out is clearly detected, there will be no refill except you will inject for a second time the contrast agent. Also here, clear diagnosis of a liver mets. Also here we find a couple of hypergenic lesions in the grayscale. They have no major vessels in the color Doppler, as we've seen it here. Once we inject, we see a couple of spots. There's a lesion, there's a lesion. So we see at least 5 or 6 liver mets show up with strong enhancement. And if you go to the portovenous phase, you see plenty of liver mets, unfortunately. Very close liver mets. Sometimes they are less than 1 centimeter, 5 or 6 millimeters, as we've seen it here. Even on these single plane, we could cover around about 20 liver mets at the same time. What about CCC? Often they have got a rim enhancement in the arterial phase. They are central hypergenic. The portovenous phase, they show hypergenic, the same as in the late phase. So there's our liver, or CCC, moderate contrast uptake in the arterial phase, and also this washout in the later phase. So the question is there a lesion? Difficult to see in the grayscale. Might be there a lesion. Okay. Or is this a lesion? Very difficult. By looking with contrast, it's much easier because you see this lesion show a moderate contrast uptake in the arterial phase. And if we shift to the portovenous phase, we could see it much easier because this lesion and also these tiny lesions show a very quick washout. And this was also confirmed as a CCC. Also here, very interesting case. So you can take your time, look carefully at the grayscale and ask yourself, did you see a lesion? Very difficult. Okay, we inject contrast. Now we will get much closer. to the diagnosis because you see there's a lesion which was not really clearly seen in the grayscale. This lesion shows also a slight washout in the portovenous phase. And if we look later, there was another one also here. So this was also confirmed as a CCC. In this case, the diameter was roughly about 2.5 centimeters. Again, late phase, clear washout. There are also some tiny other lesion as we've seen it here. HCC often show up in a cirrhotic liver, but keep in mind, sometimes you could even have an HCC in a non-cirrhotic liver. So they have got a very strong enhancement, and the washout starts later. So in the portovenous phase, later portovenous phase, starting to the venous phase, then you see the washout. Sometimes if you have got a really rare deficient HCC, you even have to wait 5 minutes, then you see the washout. So there's the HCC, you show inject contrast, strong uptake, and the washout is much later in comparison to CCC or liver mets. So we see in the center of the liver, there's a cirrhotic liver with a lesion. Also this lesion shows some peripheral vessels, also some central vessels. If we inject contrast, see a strong uptake, very, very strong. There's another one here. Portovenous phase, no washout. Then we go to the late phase. Even here, after 2.5 minutes, not a clear washout. If we wait up to 5 minutes, now you see a slight washout of this lesion. This was also confirmed as a really well differentiated HCC. Also here in the liver, we find a couple of nodules. For example, this nodule. This nodule doesn't show major vessels inside. If we inject contrast, you see a very, very strong uptake of this nodule there. Portovenous phase, there's the nodule, not a washout. Now we shift to the late phase, 3 minutes, not a washout. And after 4 minutes, you see this lesion starts to show a slight washout in comparison to surrounding tissue. This was also confirmed as an HCC. There's a couple of studies which compare conventional ultrasound in comparison to contrast ultrasound. And all these studies show that there's a benefit by using contrast in comparison if you use only conventional ultrasound. What about the sensitivity in comparison to CT? There's also a couple of studies which compare these outcome between contrast ultrasound and CT. And all these studies say that there is no significant difference in the diagnosis. So in detection of focal liver lesion, conventional ultrasound have some limitation, especially if you have got a very low contrast, as I already seen during the presentation. If you inject contrast, you will see it much faster and much more clearly. And you can say, how does the lesion behave? So you can confirm whether this patient has got a liver mets or it might be only a benign lesion. If you have got good ultrasound examination condition, then the sensitivity and specificity of ultrasound is similar like MRI with liver-specific contrast agent. With my last slide, I would like to thank you for attention.
Thank you, Dirk-André, for a very clear and concise representation of using contrast-enhanced ultrasound in assessing liver lesions. I've got one question, first of all, before we go on to the audiences. Do you do contrast-enhanced ultrasound on every lesion that you incidentally see?
That's a very good question. I do it only if the lesion was not known in the past. If the lesion is typical, like it's CEUS, I will not do it. If the patient has got an oncology disease, of course I will do it. If the patient has got a typical appearance like a hemangioma and it was not known in the past, I inject contrast. Often it's confirmed. Unfortunately, I was also sometimes surprised. It looks like a hemangioma, but unfortunately it was a mass from a neuroendocrine tumor. So if a patient has got oncologies, you have to do this. If the patient was treated in order to cover recurrence, advantage. Often you have to work as a second opinion because sometimes you find unclear lesion detected by CT or MRI, and then they ask you to give a final diagnosis.
Also, for those people working where the referrals are from primary care practice,
Yes.
and you see an incidental lesion, is it important to actually make sure you give the patient the diagnosis?
Often the patient asks us, what is the diagnosis? If the woman tell me, this lesion was known for 3 years, it was bright since 2 years, the diameter is stable, the sensitivity and specificity for hemangioma is very high. But if the patient have not known that there was no lesion, then you have to make a decision. Either it looks like a benign lesion, but in some rare cases even it's a malignant lesion. So if a lesion was not known in the past, then it doesn't look like a typical benign lesion, then we offer the contrast agent.
And this is very reassuring for the patient, of course, that you can give them the diagnosis straight away.
Straight away, no waiting time.
And very often, nearly 80 to 90% of the time, these incidental lesions from primary care are benign.
That's absolutely correct.
Yeah. I have one question from the audience, which may also be directed to me, but the question is, any experience of contrast-enhanced ultrasound in the pediatric patients?
That's a good talk. I mean, I would like to cover your talk, but of course it works also in childs. And I'm very lucky that you have done such a great work in the past, Paul, that we have got also use contrast in pediatric. But keep in mind, the dose will be a little bit different, but they're similar.
In fact, the United States has licensed SonoView, or Lumason as it's called, for intravenous use in pediatric patients for focal liver lesions. It is not licensed in Europe yet, but it'll come. But of course, all the primary work and all the in-depth assessment has already been done in Europe. So we are ahead. I have no more questions, Dirk. I need to say thank you very much for a good talk. And